I'm James Pritchett, orthopedic surgeon in Seattle, Washington. And this morning I'm going to talk to you about unicompartment knee replacement using the Persona knee. And this is a current presentation from 2021. The Persona knee came out in 2017. It was in years of development before that. It's part of the overall Persona knee system, which has a primary knee, several options, and a revision system as well. But this is the partial knee system we're talking about today. I do have some disclosures. I was a developer of the Persona knee for Zimmer Biomed. I've also developed 5 other joint implant systems, hip, knee, and shoulder. So unicompartmental knee replacements came out in the 1970s, primarily with Len Marmer initially. He was from Los Angeles. I knew him well. He's passed away now. Originally, these were not dramatically successful operations. They had a similar recovery and incision to a regular total knee, and they were brought around as a alternative to high tibial osteotomy, which was a very popular procedure in the pre-implant era. But because the operations were easier to execute compared to high tibial osteotomy, they became pretty popular. They were a little bit easier to go through. But the initial enthusiasm brought a lot of designs. There were several that came immediately on the market. Nearly everybody had one. But the results didn't hold up very well. A combination of loosening, progressive arthritis in the other compartments, and of course polyethylene wear. This was with polyethylene by current standard was not very good. Definitely wasn't cross-linked. The sterilization of the polyethylene was not very good, and of course it's very thin for use in unicompartmental knees, and those are all detrimental. So the literature came out by the late 1970s and certainly into the 1980s, questioning whether these unicompartmental or as they were called then, modular knee replacements should be done. Contralateral failure, typically it was medial compartment that was done, and then lateral compartment would get involved and it would fail that way, or they failed mechanically by loosening, instability. There's sometimes the implants themselves were not very well designed, or the instrumentation that was needed to put them in was not very reliable. And so, about the time I was in training, it was felt that there was little or no indication for unicompartmental knee replacement. That patients should just go right ahead, even for unicompartmental disease, and have a total knee replacement instead. That was the mainstream thinking, certainly starting in the 1980s, and has continued in some surgeons' minds even till today. It's an example of the type of thing you might see where the femoral component, in this case, loosened. There's polyethylene wear. There's lateral compartment wear. Overall, basically a failed case of an unhappy patient, and not necessarily an easy revision. The revision of these, because of bone loss in the tibia, could be somewhat difficult. So the operation fell pretty much into disrepute and enjoyed a very small percentage of the overall knee implant offerings. Most surgeons didn't offer them at all. There are still some enthusiasts that were hoping to bring things to a better level. What's changed now, though, that's probably been the most important aspect of interest in unicompartmental replacement is patients presenting for surgery. They're younger, they're more active, than they have been in the past. They have much greater expectations for what they want to do. They want to participate in sports. They basically want a normal knee to support their lifestyle. They're not looking for any limitations at all, and they're living longer. So it isn't uncommon now to see a patient that has a life expectancy and a need for use of their knee that goes well past the historic 20 years or so that we think a joint implant can last. And there's a lot of them. I see patients now every single day that by past standards would be difficult to treat and meet their expectations. I don't spend a lot of time trying to manage the expectations as I would have years ago. I now spend my time trying to meet the expectations of the patients. Patient selection, it's very important. We know about this now. This was not something that was understood as well. Basically, a patient that's a good candidate for unicompartmental knee arthroplasty, they have a well-functioning knee to a point. They do have pain. They might have swelling. They can't do what they want or they wouldn't be coming. But overall, their knee can be restored so it works essentially normally for them. It's an articular problem with the knee itself rather than bone loss or soft tissue deformity. The pain needs to be localized, of course. If you're going to do the unicompartmental knee, well, it needs to be localized to the medial compartment. I have them do the one finger test. Have the patient point where their knee is painful, and the one finger really needs to describe the area. If it wanders all over the knee, well, not as good a candidate. Soft tissues have to basically be normal or nearly so. So a near full range of motion. If there's deformity, it needs to be correctable. If there's any doubt, you would take stress films, for instance, to understand, can you correct the deformity? Can you understand the stability? And basically work this out ahead of time. I don't work this out during the operation itself. I know in advance whether someone's a good unicompartmental knee replacement. And it's not an either or proposition at the time of surgery for my patients. They're not dual consented. They're spoken to about a unicompartmental knee. It's decided in advance that that's the operation that is best for them, or at least one that they want, and that's the one that they get. I don't use, typically anyway, MRI, intraoperative findings, preoperative arthroscopy, all things that were suggested in the past as helpful. I'm not using any of these techniques now, but rather physical examination, a careful conversation with the patient, and the plain films, sometimes supplemented with stress x-rays. Who not to select is equally important. And that's true for any operation, of course. And this is a patient that should worry you when they come in. They have pain that's just all over. The description of what the pain is and where it comes from is not really something you're going to solve with probably any operation, definitely not a unicompartmental. So deselect these patients. This is destined not to be a favorable outcome or worthwhile for you or the patient. What are the benefits of a unicompartmental knee replacement over a total knee replacement? Well, there are benefits in appropriate patients, several, because the operations are difficult to execute. They have to be very carefully done. In most ways, they're actually harder to execute than a total knee replacement. Well, there's less blood loss. There's better range of motion. Kinematics are better. They're preferred by patients over total knee replacement. significantly lower risk of infection and other complications. Improved function with a higher level of return compared to total knee replacement. It's probably an underused procedure just now. The success hinges on the design of the implant, the patient selection, and how it's done. All these need to be in alignment to get a good outcome. You need to have the most minimal tibial resection possible. A Persona knee offers that. Possibility of alternative bearing surfaces can be important if there's a metal sensitivity issue. You need to have components that fit perfectly. The Persona knee was meant to fit actual tracings of real patients, worked out over several years by 26 surgeons collecting data. It fits perfect. These are not thumbtacks pushed into the knee, as shown here, which is not a good design or workable. Of 547 outpatients that we've done, we do them all as outpatients. No one was hospitalized, just 2 infections. There are 24 revisions for various reasons. 92% had good or excellent results. 5% have any functional limitation at all. 3% were less than good or excellent. It means they didn't get the pain relief that they wanted typically. 86 prefer their unicompartmental knee replacement over a total knee replacement in a paired bilateral study. This has been published. Infection, of course, is a problem. Here's one. This is not a Persona knee where an infection occurred and it was removed and spacer was placed. It was resolved easily enough in many ways. It's easier resolution than a total knee infection and much less common. There are occasional disease progression. Here's one where lateral compartment disease developed after an Oxford, and it was treated by placing a lateral compartment, maintaining the medial compartment uni. Wasn't converted to a total knee replacement. That's an advantage, can be done it on many occasions. There can be complex revisions, and this is why you have to be careful in selecting a minimally bone resecting tibial component. Here's a failed Oxford, required a cone and a stemmed implant, was a good outcome. Things on the horizon. Here's something we've been doing in suitable patients where we use 2 unicompartmental replacements to really be a total knee, to avoid the stress shielding that a total knee can provide and also keep both cruciate ligaments. Patellofemoral arthritis usually isn't a problem, but if it is, here's a case where bicompartmental prosthesis was done, where a unicompartmental knee was matched at the same setting with a patellofemoral arthroplasty. These procedures, both 2 unicompartmentals or a bicompartmental, have some cost, of course, and they're not as attractive for that reason, but they're very helpful on occasion as far as outcomes and patient satisfaction. This is what that would look like intraoperatively. Thank you.